Good evening and thank you for joining Medical Channel Asia's online webinar, Doctor on Call. I'm Shan Ping, who will be your MC for tonight. Today's event is proudly organized by Medical Channel Asia, your one-stop solution for Asian health information. Make sure you check out our social media pages. We are also grateful for you to have come in early today to join us in this webinar. With us today, we have many attendees dialing in from across Southeast Asia. Thank you to everyone present, and I'm sure that this will be a fruitful and engaging session. Just before we begin, a little housekeeping. If you have any technical difficulties, just type your questions in the chat box on the right. If you don't see it, click the single speech bubble icon. These questions will be immediately attended to by our technical support team. If you have questions for Dr. Radhika to answer, please feel free to type them in the Q&A box, where it will be answered later on during our question and answer session. To maintain anonymity, do remember to click on the Send Anonymously checkbox before you post your question. For those watching live from Facebook, hi! You can put in your questions as well under the comment section, or if you would like to maintain anonymity, do send a direct message to our Medical Channel Asia Facebook page. Now let's invite our host of the event, Mr. Jason Lim from Medical Channel Asia, to say a few words first.
Very good evening, everyone, and welcome to this event organized by Medical Channel Asia. My name is Jason. I'm one of the founders of Medical Channel Asia, and we have a team that works tirelessly to try to create good, credible medical content for everyone here to consume all across Asia. And part of what we do is to invite specialists, people who are really renowned in their field, like Dr. Radhika tonight, to actually conduct these free health webinars in an effort to promote a healthier living and a healthier way of life, right? So I'm really grateful to Dr. Radhika for taking some time this evening to join us and to conduct this webinar on our behalf. Now, for all of you who are dialing in from all over Asia into this webinar, I'd like to invite you not to miss any of the content that we've been putting together, that our team has been writing and producing in terms of videos and all that. I'd like to invite all of you to go and follow us on social media. You can find us at all our channels, just Medical Channel Asia. That's the handle that we use. And especially, I'd like to invite you to go to our YouTube channel, which is youtube.com/Medical Channel Asia. You should see in the chat box right now. Just click on that and go to that channel and click subscribe. And the reason why I'd like you to do that is because we have so much good content coming up in the next few months, and I wouldn't want you to miss a single one of those, right? So join us for all that. Follow us on social media and just sit back, relax, and get ready to have your questions answered by Dr. Radhika tonight. Back to you, Champagne.
Thank you, Jason. So our special guest and speaker tonight is Dr. Radhika Lakshmanan, who will be debunking the myths and pointing out the facts about breast cancer. Dr. Radhika is a consultant breast and general surgeon who practices at Farrer Park and Mount Elizabeth Novena Medical Center, Singapore. She is a trained general surgeon who, since coming to private practice, dedicates her service to mainly breast conditions ranging from benign to malignant, also known as cancerous conditions. She is a graduate of the National University of Singapore, and she obtained her postgraduate Masters of Medicine in Surgery and Fellowship in General Surgery from the Royal College of Surgeons, Edinburgh. She did advanced training in breast conditions, namely breast cancer, for a year in the Nottingham Breast Institute, United Kingdom in 2010. Her subspecialty in breast surgery lies in oncoplastic breast surgery. Dr. Radhika is also fluent in English, Malay, and Tamil, and is not a stranger to public awareness talks on the breast cancer in collaboration with the Singapore Cancer Society and the Breast Cancer Foundation. Dr. Radhika, please.
Hi, everybody. Thanks for spending your Thursday evening listening to a health talk. I would like to thank Channel Asia for inviting me to give this talk and give this opportunity to share the information on breast cancer. Right, so before I start formally, apologies. About that. Yeah, so why do we need to talk about breast cancer in the first place, right? Sorry about the slide. So yeah, okay, got the first slide. Before I go on to the topic proper, basically, I think most of you know that breast cancer is the most common cancer affecting women in the world. And it actually doubles up as the most common, unfortunately, most common cause of cancer death in women in the world as well. And the third fact is also, which is not very well known, is that it's the most common cancer which affects ladies in pregnancy and breastfeeding. So that's something which is not commonly addressed or informed. So you can see the reality is that it's very, very common. And that's the reason why I'm giving the talk. I think it's very important for everyone to know the facts and take care of yourself in that sense. So I'm going to start the talk proper. So, a lot of my patients, when they're diagnosed, actually they will tell me that they thought that cancer would only affect older people. We're talking about people in the late 60s or 70s. But the fact is actually the peak age of cancer, and we are talking about, my data is mainly based for Asian population, and I understand that some of the audience are from out of Singapore in the Asian region. So peak age is actually between 40 and 69. So it is not like the peak is not 70s. In the Western population, the peak is actually above 50. So in Asia, it's like a decade younger than the Western population. Now, the other thing which I see is that, which is quite natural, I suppose, a lot of people would think that, in pregnancy, and is one big issue to deal with already, so nothing else can happen. But actually, as I mentioned just now, it's the commonest cancer in pregnancy. Okay, but thankfully it is not common, as in it's not common to present in pregnancy, but it does. And also it can also present when you're breastfeeding. So ladies who breastfeed well, on one hand, people tell you, oh, it's good to breastfeed. There's data to support that breastfeeding supports or prevents breast cancer. But that data is only for a period of 6 months. The supportive benefit of breastfeeding is only been shown for 6 months of breastfeeding, protects you. But if somebody breastfeeds on and on, especially if nowadays ladies are having their children a bit later in life, and if you continue breastfeeding for 2 years or more with no break in between and no assessment of the breast, nobody can guarantee that something is growing in the breast. So it's always good to actually at least have an assessment if you intend to have prolonged breastfeeding, right? And because a lot of ladies, when they're breastfeeding, they think this is a blocked up. This is probably the breast is engorged with milk. It can't be a lump. How can it be a lump? Okay, so if there are gentlemen out there, please be wary of this fact as well for loved ones. So the other thing that people always think is that they think that it usually presents at a very advanced stage. No, sorry. What I mean to say is that because it's easily missed during breastfeeding, when the lady presents to us, the tumor has grown quite big and usually presented at one stage because the patient had disregarded it, and not even the patient would have seen non-breast specialists, the GP or other non-breast specialists, who would also again disregard that. This is probably related to breastfeeding. Don't worry about it. No, you should worry about it. You must get it checked. As long as you get it checked, you're fine. Now, the other important data that we have in the last 1 decade is that in Asian population, about 20% occur in less than 44 years of age. So we are seeing more of young breast cancer patients. We're talking about late 20s to, as the data here, up to 44 years. So we're seeing people 30, 35, 40, 45. So ladies out there, don't be complacent. It is not normal to have a lump in the breast, no matter what age you are. Okay, so just be wary of that. So The other thing is that now breast lump is the most commonest presentation in breast cancer. So a lot of women think that, so I don't have a lump, so I don't have to worry. Why do I need to do a mammogram? Okay, you don't need to worry because only 70% of breast cancer present with lump, 30% don't. So how do they present? So they present with, abnormal discharge from the nipple. There are a lot of normal discharges from the nipple actually. So a lot of normal discharge have creamy discharges. These are due to the nipple ducts being a bit engorged and some inflammation. But abnormal discharge refers to usually is like colorless or blood-stained. The thing is, you're not sure, you have to get it checked. Make sure that it belongs to the normal category, right? Now, a lot of women who come to the breast clinic, they actually come with pain, right? So, and they're worried that, oh no, something must be wrong. Well, the good thing is actually that most of the time pain is associated with benign conditions, that is non-cancerous condition. However, 8% of breast cancer patients do present with pain, right? But majority don't. Majority is due to hormonal changes in the breast, right? Now, the other 8% is screen detected. What does that mean? It means you don't have a lump, you don't have a discharge, you don't have pain, nothing. You feel absolutely normal. You feel great. You run 10 clicks a day, But the mammogram shows an abnormality, and that turns out to be cancer, right? And that's called early detection. So that's only found when you do the screening. So the 8% of cancers are found in that way, right? Now 4% present with itch. Itch, we are referring to itch mainly around the areola, which is the surrounding pigmented area around the nipple. And about 2% present with deformity. Now, this deformity and all that sometimes is written in your brochures for identifying breast cancer. But I like to highlight, once there's deformity, we are dealing with probably advanced cancer already. We really don't want to see deformity in this day and age, right? But you have to know, you have to understand that. Because some patients think, oh, the breast look a little bit odd than before, but hey, I don't have pain, I can still jog, I can still run, I can still cook for my kids, so I should be fine. No, it's not fine. Abnormal breast shape is not normal, right? So we got to get it checked. So despite saying already gloomy facts, the consolation is actually 80% of lumps are actually not cancerous. So it's very common for women to have benign breast lumps. So that's the saving grace here, right? So if you can have a lump, don't think, oh no, I'm finished, I've got cancer. Just get it checked, make sure it's normal, that's it, right? So basically you need a workup. Now there are a lot of patients ask me, oh no, is it underwired bra promotes cancer? No, it doesn't. There's no evidence for this. Oh, I can't wear deodorant. Is it also with aluminium and all that? There's really no evidence for this because it's a topical application of chemicals. It does not, there's no data to show that. Implants, when you want to, aesthetically improve the breast outcome, or rather what we call augmentation of the breast. There is a small category of implants which does lead to breast cancer. This was found in the last 5 years. So actually it's a fact, it does, but we're talking about 4% of implants causing cancer. And it's a particular type of implants. When ladies go for implant surgery, actually many types, there's at least 20 types of breast implants. So the implant which causes breast cancer is only a certain type. We call it, sorry, the name slips my mind, but it's the implant is the rough type. Okay, it's the rough type, it's not the smooth contoured type. So a particular type, we call it, yeah, it just slipped my mind. But anyway, this particular type implant is banned in Singapore. I'm not sure about the rest of Asia, but because the data came out that it can promote lymphoma in the breast, it's been banned. Right. So the facts are that, all the vices in life are, usually bad, bad for health. The smoking, alcohol, we're talking about excessive alcohol. We're not talking about, a social wine once in a while. We're not talking about that. Now, obesity is a definite contributor or risk factor for cancer. Now, the other thing a lot of people think is that, hey, how is it, doctor, you see I've got cancer? There's no one in my family who has cancer at all. So I can't believe it. This must be wrong, you know, because there's too much hype in the media about, you know, some celebrities having you know, cancer or inherited genes and all that, like Angelina Jolie. So somehow when the media shows certain facts, it just gets, you know, thrown away in people's mind. So actually the fact is only less than 20% of cancers are inherited. Now, what does that mean? That means 80% are not inherited. What we call sporadic. So we don't know why, right? We don't know why it's not inherited at all. Now, the other, I put this slide up because I find that sometimes when ladies have a problem with the breast, they really don't know who to see because they think that, you know, oh, the gynecologist deals with all the women problems, so they should be the ones looking at it. Now, I'm speaking for Singapore here. I'm aware that in some parts of Asia, the gynecologists do a breast check as well. So this statement only goes for Singapore. So in Singapore, gynecologists only look after the babies, you know, when you're pregnant and you know, any gynecological problems like a menstrual problem and all that. Now, some patients go and see the oncologist. Now, oncologists, so that you're assuming that, you know, if a lump, 100% you have cancer. No, you don't. Like I told you, 80% are benign. Oncologist is someone who can treat cancer. So you need to give them cancer first and then they can treat it. You give them a lump, you tell them to evaluate. They're not the right person. So basically a lot of time and, you know, everything is wasted. A very simple example is, let's say your tap in your kitchen is not working. You need to get a plumber, right? You don't get the electrician for that. They all work for the house, but you know, you don't get the wrong specialist. So you get the right plumber, then you get it right. So the right person is the breast surgeon who nowadays we are all trained in general surgery, but we subspecialize. Like for colon cancer, there are colorectal cancer surgeons. For gastric cancer, there's gastric surgeons. So likewise for breast cancers, we are general surgeons who do subspecialization in breast only. So because things have advanced so much, there's a lot of detailed treatment that is necessary or required by specialists to be aware of. That's why you got to see the right person. Okay. So I think I alluded to this just now. So I don't feel any pain, so I should be fine. Which is, you know, human nature, pain is associated with disease. But somehow for breast cancer, it's usually quite silent. There's no pain. There can be a lump, but it's painless. So it doesn't mean there's a lump that's painless. It should be fine. It's not fine. Okay. So like I said just now, about 8% of breast cancers are painful. More than 90% are not painful. Okay. And like I said just now, pain is due to hormonal changes, right? Like when you get a cyclical menses, just before that, about 25% of women get fullness in the breast, a bit of tenderness, a bit of hypersensitivity. That's because of the hormonal changes. Now, so don't be complacent. So I find that a lot of women feel that, oh, you know, I did all the right things a woman is supposed to do, which is I got married early, I had a child at a young age, I breastfed my kids for 6 months, so I should be protected against breast cancer, right? Now, these are good associations, but it is not absolute. That's what I'm trying to say. These are not absolute. You know, to be honest, when people ask me, you know, how come it's me? Why? These are questions we can't answer. Honestly, we don't know the cause of breast cancer. We do know that less than 20% is inherited, but the 80%, we don't know why people get cancer, right? But at least we know how to deal with it and recognize it. Now, the other thing I want to highlight is that, you know, a lot of data that you Google and you see, the risk factors of breast cancer, most of that is for the Western population, right? Now, most Asian women don't use contraceptives, right? Most Asian women don't smoke, don't take alcohol, although I think the last decade or so, that incidence is rising. But there is a data in Singapore in the literature which says that the percentage of these patients with cancer and these associations are very, very low. So in fact, most women with breast cancer don't have a risk factor, right? So basically, we don't really know why, yeah? So you can be healthy one day, like I said, you know, running a high-profile job, you're exercising, you know, you're perfect, you do everything for the family. Next day, doctor tells you you've got cancer. It's like, it can't be true. So that's what I'm trying to say. It's a silent disease. right? The silent disease. Now, so there's a group of women who says, oh no, I don't want to do all this screening, you know, the X-ray will kill me or make me have cancer. Now you think about it. When I mentioned just now that about 8% of cancers are screen detected. That means you don't have a lump before in infancy, just like conception, right? Where a baby is conceived, you can't see it on the scan. Right? You can only see it in, I can't remember, 20 weeks, I can't remember how many weeks, 6 weeks, 4 weeks, something like that. So you need it to develop in order to capture on the scan. So when in its infancy, you can't see it. So that's what the mammogram is trying to do. It's trying to catch it in the infancy, right, at conception, so that it's not too late. If it's too big and it spreads, then it's a bit too late. What does it mean by too late? It means that your treatment will be more complicated, your prognosis, that means your success out of the treatment will be diminished as your cancer advances. So that's why we're trying to do mammography. Now, it does not cause any risk of cancer. Are you aware that, actually radiation is everywhere, even in this room while I'm talking to you, in the Zoom, there's also radiation. So mammography radiation is equivalent to a flight that you take. Of course, nowadays we can't take a flight because of COVID, but that's all the radiation is. And before COVID, I'm sure most of you are flying here and there. So if you can fly here and there and have that kind of radiation to yourself, then why can't you take a mammogram? Now, having said that, mammogram is not end and all. Just like everything in medicine is not, it's not 100%. It's a whole picture that we look at. So 8 to 10% of cancers are missed in the mammogram, right? So normally we do complement it with ultrasound scans of the breast and a doctor's examination. Now, a doctor's examination, I have to highlight, better to see a breast doctor's examination. We're not talking about a general practitioner. I'm not trying to say general practitioners are not competent to do that, but if you have a lump, you must see the breast surgeon, because sometimes people disregard a lump as, oh no, this is just lumpy breast. It's nothing. But what I'm trying to say is that if you feel something, you must do the imaging and prove it beyond doubt that there's nothing there. The doctor cannot examine and say that, oh, there's nothing there. That's not good enough, not in this day and age. So now, how do we diagnose breast cancer? Okay, so all these breast imaging, X-rays and all that helps us to support whether there's an abnormal growth. Now, there's an abnormal growth does not always equal to cancer, right? So how do we prove? We need to prove so that we need to give treatment, or we can tell you good news that everything's fine. The only way to do that is by doing a biopsy. A biopsy means we put a needle into the area of abnormality and we take a small tissue sample out. It's a very simple procedure done in the clinic, done under local anesthesia. It can be done in as fast as 20 minutes. But I find that some people even have qualms about this. They say, oh no, I heard that doing a biopsy will make the cancer spread. It'll be worse. Now, if you don't want to diagnose it, then what are we going to do? But anyway, to put the facts right, it does not for breast, okay? For cancers, like things which are in the abdomen area, like the stomach, you can't do biopsy through the skin. That may cause spreading within, or the ovary for that matter. So anything within, inside your abdomen or pelvic area, that can cause, but not for breast. So that's how we diagnose. And it is based on the biopsy results. So I think I saw a question earlier on, something about how maybe I'll address it later. We'll just carry on with the talk. Now, if I remove, so we're coming to the treatment, yeah. So the mainstay of treatment for treatable breast cancer, what does it mean of treatable breast cancer? It means that early breast cancer, it means stage 3 and below, right? If it's stage 3 and below, it's treatable. If stage 4 means we're looking at advanced stage, that means we've missed the boat in terms of treating it, because the tumor has spread to some parts of the body or all parts of the body. So we are talking about treatable breast cancer. Now, for treatable breast cancer, some people think that, oh, I'll just do the most drastic surgery. I remove the breast. then I won't have to do silly things like chemotherapy, which will harm me and all that. Okay, so that is not correct. Now, some people think that if I remove the lump, 100% I must do chemotherapy. That is also not correct. And some people think, oh, let me do the chemotherapy and then the tumor goes away, then I don't need surgery. Okay, all incorrect, yeah? So the type of surgery and the chemotherapy is independent of each other. Surgery is surgery. Instead of treatment for breast cancer, treatable breast cancer is surgery, one arm. It is there, always there, 100%. Okay? And whether you need chemotherapy or not depends on other factors like your stage and the biology of the tumor. It does not depend on how we do the surgery. So this is what we call multimodal treatment. That means we involve multiple specialties dealing with cancer patients. So I'm only one arm of the whole treatment, so-called protocol. I'm the surgeon. And then we have medical oncologists, we have radiation oncologists, we have breast care nurses, dietitian and all that. So those are what we're talking about, comprehensive management. Then you get higher success rate of treatment. So this is what I mean by comprehensive treatment. But it's not that every single patient gets everything. So it really depends on your tumor biology, your stage, your type of cancer you have, type of tumor you have, size of the tumor you have. So that depends on what type of surgery is done, and that will determine if you need chemotherapy at all or not. There are some patients with just surgery alone, nothing else is required. Some patients need everything. Some patients need surgery, chemotherapy, and the tablets. Some patients need surgery and radiotherapy and the tablets. Some patients need chemotherapy before the surgery, and then the surgery, and then a tablet. So there's various cocktail of combination of treatment. So no one size fits all. It's really very tailored to you. So yeah, so why is my relative's breast cancer treated differently? Why did they remove the breast from my relative? So it really depends on the what we call how big the tumor is, or where is the tumor in the breast? Is it all over the breast? If the tumor is all over the breast, then obviously you have to remove the breast. Or if the tumor is in a very big portion of the breast, like 3/4 of the breast is involved by the tumor, then it doesn't make sense to leave a little bit of tissue there and remove 75% of the breast and subject that little portion to radiotherapy and chance of cancer coming back. Right? So it doesn't make sense. So that's how we decide on what type of surgery to do. But of course, it's not very straightforward. There's a lot of variations to that. Yeah, so it depends on the difference in behavior, the biology of the tumor. So your aunt and yourself, you both have stage 1 cancer. But when you dissect, you look at the cells under microscope, both cells are different. So breast cancer, I put this picture up, because you go to the fruit stall, you ask your wife to buy fruits, but which fruit to buy, Is it watermelon? Is it banana? Is it, blueberry? What is it? They're all fruits, but they're quite different. Breast cancer is also quite different. No one size fits all, they're quite different. So that's why the treatment response difference and difference in the relapse. Now, a lot of women fear that surgery means they will lose the breast. It will cause a lot of pain, and they will make them less of a woman, make them very dependent. Actually, breast surgery, whatever type of surgery you do for the breast, usually the pain is very minimal. In fact, sometimes it's almost nil. And I'm not saying this, what all the patients say, because it's very minimal surgery. We're not doing surgery like inside the abdomen, as I said before, that causes, significant pain. And even if the breast is required to be removed, we can do a lot of things nowadays. We can do reconstruction. So you don't have to worry about ugly shape and scars, and you don't have to be embarrassed, because our aim is not, is not to disfigure you more. We already feel that it's bad enough to get cancer. So the advances in cancer surgery now, we call oncoplastic breast surgery, which is a marriage between plastic surgery and cancer surgery to give you a more aesthetically shaped, breast. Yeah, so I think I alluded to this. We remove the breast, you need a total breast recon. If you remove the lump, then you will need radiation treatment of the breast. And breast cancer surgery is not always dealing with the breast lump alone. It's actually twofold. It deals with the tumor and the lymph nodes in the armpit, right? That is also tackled during breast cancer surgery, right? Now, after seeing all the bleak facts, at least there's some saving grace again. The 5-year survival rate for breast cancer, it's improved tremendously. Why is there so much research for breast cancer? For the treatment, the treatment for chemotherapy, for the tablets, even for the radiation, has improved so much. So the 5-year survival in the 60s was 63%, now it's more than 90%. You have stage 0 breast cancer, it goes up to 99%, right? But of course, you have stage 4 that dropped to 25%, right? So I'm trying to say it's not a death sentence, right? It can be treated. Now, worrying about hair loss. So nowadays we have what we call cooling caps to reduce or diminish, hair loss. And you don't have to worry. Once the chemotherapy stops, the hair will grow back immediately. Now, so does all patients need chemotherapy? So there used to be a time when, oncologists would say, oh no, you have cancer, you need chemotherapy. Now we've got a diagnostic tool here which actually can test whether chemotherapy will benefit you or not. Now we're not talking about advanced breast cancer, we're talking about early breast cancer here, so I have to highlight that. But this particular test can only be done in a certain subgroup of breast cancer. They have to fit into this biology where we call the receptor status follow this category of ER positive and HER2 negative patients. So, right, so as you know, the risk of cancer does increase with age. Aging population does have a higher risk of cancer in general, all kinds of cancer. But the number of people being diagnosed and living with cancer is going to rise because our technology has improved so much, right? So people are going to be living with the cancer rather than fearing to live with the cancer. So this was the data in Singapore. So it found that between 2006 to 2010, and compared to 2011, 2015, there was a significant increase in the survival of breast cancer. So I think that's the end of the talk. Thank you very much.
Don't forget to like, comment, and subscribe for your regular dose of Asian health information.